Hello, my name is Joshua Campbell, and I look forward to sharing with you 7 ways to improve patient care with 3D implant dentistry and guided surgery on this May 20th, 2015. Welcome from around the world and all different time zones. Also, thank you to Dental XP and Dentsply Implants for the opportunity to share with you something that I truly love. Also, thank you to all the wonderful dental professionals and practitioners that I get to work with and collaborate with them on patient care. Also, thank you to my partners at Oral Surgery Specialists of Tennessee. Thank you to Travis Witherington, Andrew Chung, and Lindsay Nagy for the opportunity to work with some truly wonderful technology with the Cone Beam CT and our 3D planning software to do some truly unique things in our field. And we are all oral and maxillofacial surgeons. I'm originally from Minnesota. However, my alma mater for dental school is the University of Iowa. Go Hawks! And my alma mater for oral and maxillofacial surgery is the University of Tennessee at the Medical Center in Knoxville under Dr. Carlson. Thank you to him for the opportunity to do what I'm doing every single day. And it's been fun to give back and share with that program through teaching the dental implant curriculum. Also to share with the residents at Vanderbilt University as an assistant clinical professor. Also, I've had the unique opportunity to share both locally, regionally, nationally, and internationally about topics related to 3D dentistry and guided surgery. And it's been wonderful having those opportunities to share as well. The material you'll be seeing, I usually teach within a day course, so I had to pick parts and pieces that could hopefully be digested over an hour. And we're going to focus on 7 different ways to improve your 3D digital dentistry and guided surgery. The 7 S's, the smart planning, scanning, surgery, inventory, temporaries, final abutments, and collaboration and education. Hopefully you enjoy this webinar and get something out of it, whether you are an experienced practitioner in the digital dentistry world or someone who's just getting started. Enjoy. Prior to jumping off into the 7 different ways, I just wanted a quick terms review. The first term is DICOM. It stands for Diagnostic Imaging and Communication in Medicine. It's the raw data that's collected from the Cone Beam CT. This is a picture of our cone beam. We use the iCat. That raw data can be quickly viewed through a volume rendering. And you can see over here, this is a volume rendering. You can see bone, tooth, there's soft tissue. All the data can be seen in a volume rendering. In image segmentation and editing, it allows you to select specific parts of the DICOM volume, specific grayscales. And this would be an example of a specific part. You can see the bone and the teeth only. The next term is .stl, which stands for what I used to think was stereolithography. It's actually standard tessellation language. It is essentially the JPEG of the 3D world. This is an example of an STL file. They can be acquired through a model scanner or through an intraoral scanner, and you're basically digitizing the patient's dentition, whether it's directly or indirectly, through a model. And then all this information, all of the DICOM information, STL files, they can be worked up in the patient's planning and throughout the whole patient's treatment to create various things, whether it be temporaries, permanent, crowns, surgical guides, just about whatever you can think of, you can make these days. But you can do that through additive manufacturing or milling. So additive is just adding layers, milling is subtracting, making copings, crowns, that sort of thing. But you can make the virtual a reality. So thanks for that quick terms review. On to the 7 ways. Now that we're done reviewing terms, let's move on to our objectives. Our first objective is to look at smart planning. And I can't emphasize enough the importance of 3D treatment planning and how it allows the prosthetic plan and the surgical plan to be mutually compatible. When you're planning, if you're first starting out, start quote-unquote simple. Start with a case you would normally do without 3D and without a guide. You need process and kit familiarity when doing something new. So each time I try a new kit or new process, I like to dial it back to simple and then kind of work into the complexity from that point. So start simple, then get as complex as you want. And each step you add into your workup will add complexity. So I just really want to know each step as I'm going along and learn it well, and learn it on a case that is much simpler than one that is more complex. So, but if done correctly and with the correct understanding, the smart planning will ultimately simplify the end result, and planning with 3D digital dentistry will ultimately simplify the end result. Instead of getting to the end and being concerned about custom parts, this and that, you still may need those parts, but at least you will know what you need. So how is complexity added during the planning process? Well, it's added through including the final prosthetics. And how do you go about including the final prosthetics? And we're going to be talking about that a little bit later on with smart scanning, so with optical and dual scanning. But including the final prosthetics just adds another layer of complexity, not just for yourself. If you're the surgeon like I am, working with a restorative doc, but also for your staff and the training that they need in order to accomplish the goals of including that final prosthetics. The addition of multiple implants increases the complexity. You have to not only know where the implant is in relationship to teeth and in relationship to anatomy, but also in relationship to other implants, not just in proximity, but also in directionality and depth and path of draw. Smart planning extends to digital models, and again, this has to do with the final prosthetics. It has to do with digital models for tooth-borne guides. There's lots of reasons that you need digital models. Temporary design and abutment design. There's lots of different reasons for that, but that adds a layer of complexity. Again, scanning prostheses, and there's several different types. Dual scan and optical scan are the ones that we'll be focusing on today. And then merging multiple scans, this relates more towards dual scan, and again we'll talk about this under smart scanning. If there's a new guided implant system or kit, that does add layers of complexity, and there's also a new process typically with a new implant system or a new kit. And also smart planning extends to planning abutments, both stock abutments for immediate load cases and also for custom abutments. And there's some neat things you can do with custom abutments as well. But that plays into the planning. So with smart planning, the sky's the limit when planning 3D implant dentistry and guided surgery. However, technology and product should never supersede sound surgical principles. Don't think just because you have the technology, everything's just going to get easier by adding in technology. And in fact, it could get a little bit more challenging for a little bit until you understand how the parts and pieces go together of 3D digital dentistry and how the processes go. So sound surgical principles are key, not only in your everyday surgery, but also in 3D digital dentistry and guided surgery. And also, technology and products should never supersede sound diagnosis and treatment planning. And this definitely rings true as well. If you don't have your diagnosis and treatment planning down, it's hard to come up with your final prosthetic plan. If you don't have your final prosthetic plan, it's hard to scan that into your cone beam CT via dual scan optical scanning. So the diagnosis and treatment planning is key. It's key for the single implant, multiple implants, for full arch cases. So you got your single implant, your simple implant. We'll be looking at this case a little bit later on, but your simple implant can even be can even be something that is improved upon through 3D digital dentistry and guided surgery. You can improve the directionality, the depth. You can order custom abutments prior to the surgery if you're doing things guided, and we'll talk about that a little bit later. Also, when you're doing full arch cases, it's very nice to have that final prosthetic plan that you're using for your guide in placement of the implants. And this was planned with implants that were angled and corrected, and so the path of draw would be symmetrical all the way around the arch. And it's very, very difficult to do freehand. With the new technology that we have, we can really, really hone in on our final prosthetic plans. And so I'm going to shift over here, and I'm going to show you a few different cases. Here's the first case. I'm going to zoom in just a little bit. You can see, and I'm actually using the Implant program for this, but you can see how we have a single implant. But what we've done is we've acquired the DICOM, so you can see the bone. You can see there's a nerve right down here. You can see the implant showing up through the translucent model. If I take away the mandible, you can see where the implant is in relationship to the nerve. You can see that we've scanned in and digitized the patient's arch. And we have also included the wax up, which is the final prosthetics for planning, and we can really zero in on where we want that path of draw of the implant and the depth of placement of the implant. And we're able to order a guide to allow for us to place this implant to this depth and this direction. And we can take that even a step further. We can also order a custom abutment, and we'll talk about that a little bit later too. So even the single implant case, the simple case, you can, I found that you can significantly improve the results by using guided surgery, just even with the quote-unquote simple cases. The next case I was going to look at with you real quickly in the diagnosis and treatment planning part is a gentleman who we worked on and placed multiple implants and immediately loaded his upper arch. You can see we have planned his implants off of a denture that he wears, and one that was recently made. And it's really important when you're planning your cases, when you have a denture or prosthetics, whatever it is, you want it current. This is a current denture. This is the final position of the teeth when we're all finished. If the patient has an old denture and the teeth aren't correct, you're probably not going to want to do your planning off of that. You're probably going to want to make a new denture and then plan off of that. So you can see we have all of our paths of draw on the implants are all through the areas of the scanning prosthesis, or the dual scanning prosthesis that we would want, and they're fairly symmetrical. And you can see we decided not to angle correct anything here because we were well within the 20 to 40 degrees that is necessary for the conical abutments that go on at the time of an immediate load. And then we can even get a little bit more complex in our planning. I'll zoom in a little bit more here. So we can go from planning implants where the path of draw is correct and we don't need to angle correct anything, to planning abutments. And you can see we've done a dual scan here. We've scanned a denture in. You can see the fiducial markers, and we'll talk about that a little bit later. But we were able to angle correct various implants in this particular patient and plan for what abutments we will need in the final prosthetics. Zoom in a little bit more. And you can see our angle correction on our implants through the abutments that are on there. And this is all done before we ever do any surgery on the patient. So I can't emphasize enough that with smart planning, the prosthetic plan and the surgical plan are mutually compatible. So all right, so let's move on to our next objective. All right, let's move on to our next objective, which is smart scanning. All right, with smart scanning, you're inputting the patient data into the planning software, whether it's the patient's dental arch without the final prosthetics included, or dental arch with final prosthetics, whatever data it is that you're inputting to help further the patient's 3D workup. And there are two ways I recommend to do this for inputting the patient's data in your workup. The first is dual scanning. The second is optical scanning. These are some different examples of the types of ways you can input the final prosthetic plan into your 3D workup software. One way that is a very traditional way of doing it is getting a CT with a barium scanning appliance. You do need that at the time of the scan, and there can be quite a bit of scatter that goes along with it. You can actually add virtual teeth in some of the planning software. The virtual teeth are not based off of any actual workup that was done with wax-ups or dentures, but it's a close approximation. However, the best way that I feel like to input the patient's data and the prosthetic plan is through doing a dual scan prosthesis, inputting the denture, flipper, whatever removable partial or denture that they may have. You can input that through a dual scan, and we'll talk about that. You can also input a model and wax-ups through optical scanning. And what's neat about this technique is you can acquire the cone beam CT, and then you can optically scan the patient's models and their wax-up and add them later on to the cone beam CT. So you can include the final prosthetics later on with this, and it's a really nice technique that does not have the scatter associated with it that the barium appliance does. So the dual scanning technique, one way I like to think of it is the dual scan technique is 2 cone beam CTs of the scanning prosthesis and 1 cone beam CT of the patient. So dual scan. It sounds like there's 3 scans there, but there's not. With the dual scan, one of the scans of the scanning prosthesis or the denture is of the denture by itself. So you place the denture or the scanning prosthesis, whatever it is that you're performing the dual scan on. It's typically a denture. You're placing that in the scanner, acquiring a scan of it, and then you're taking that same denture and you're placing it in the patient's mouth and you're scanning it again while you're scanning the patient. So you're scanning it with the patient. So the patient only has to go through the scan once, but the scanning prosthesis goes through twice. And how this works is when you scan the denture, PMMA, or acrylic, has about the same density as the gum tissue. And it's very difficult to separate it. When you look at the scan, it's hard to separate the density because the density is basically exactly the same. It's really easy to look at the difference between the acrylic denture and air. There's a big difference between the two there. And so this is what dual scanning takes advantage of. And what we're looking at here is Hounsfield units. Distilled water is the standard and is defined as 0, and air is minus 1,000. So that just kind of gives you some reference for what we're looking at. But with dual scanning, what you're taking advantage of is the differential in densities. And so we'll look at that a little bit more when we actually merge dual scan together. So we're gonna do that in a second. But to really make this work, we need to have markers on the denture that are radiodense. And so you can purchase some of these glass beads, and you can either glue them on somehow to the patient's denture, you can embed them into the patient's denture, or you can get a product that we use the most at this point, and they're stickers with a radiodense marker on them. So whether you use the markers that you embed or glue or the stickers, you need something that you place onto the scanning prosthesis. You don't want to put them on the teeth. You don't want to put them on the antaglio surface because if you do that patient will not be happy when you try seating the denture or scanning prosthesis in their mouth with markers in place. That can be quite painful. That has happened at our office, but that was all part of the learning process. So I'm telling you now, so that doesn't happen in your office. So anyway, the markers are what are used to merge the scans. The markers are in the same place on the scanning prosthesis in both scans, when the denture is scanned alone and when it's scanned in the patient's mouth. And that is how you marry the two scans together with those fiducial markers. So let's look at some examples in the planning software. Here's an example of a dual scan that we did. You can see that it's a maxillary dual scan. This is my 3D object that I've segmented and edited out. And if we look closely here, we can see that where the bone is at, and then you have gum tissue, and then there's denture, but I can't tell the difference between the two because why? Well, they're the same density. But if you look at the air here, the air is the dark, and you can really tell a difference between the air, the soft tissue, air, and bone. And so if we go around the patient's arch, we can start to pick up and we see the markers. So we've scanned this dual scanning prosthesis in, which is the patient's denture, and it's the correct denture. It's the denture that the final prosthetics will be made off of. You want to make sure that you definitely have that. You want to make sure the denture fits appropriately as well. But you can see here's one of the markers, and so that marker is going to help us marry the two scans together. So let's do that now. We'll get back to our 3D view and go to the dual scan wizard, and we outline the area of interest. And with this particular gentleman, it's not as important just because he is edentulous in the upper arch. But I still do it anyway because it reduces the amount of area that the software is looking for these markers you can see there. So you can see there's a marker there, there's a marker there. You can see all the different markers. Alright, so let's hit next. Patient is edentulous. Hit next. Now we have to find the prosthetic data. It should be right here. And so we're going to upload the scan of just the prosthesis itself with the markers in place. And again, the markers are the same in the scan we've just been looking at and the scan that we are importing of just the prosthesis or the scanning prosthesis. So as it's importing, we wait. And there we have it. You can see the scan of just the denture itself. And I'm going to adjust the threshold. And again, if we drop all the way down to that -1000, we pick up everything. This whole box right here should turn green because we've selected all the densities in that box. We do not want to do that. We just want the density of the denture and the fiducials though. But I wanted to show you what that looked like. So now we've just selected the denture and the fiducials. We have not selected air. So we're going to stay away from that. But I'm going to just double check that we've captured the whole denture within this box, and we can actually shorten this up just slightly. There we go. And one other key thing when you're doing a dual scan, you want to make sure that the denture is scanned. If it's a maxillary denture, you want to scan so the teeth are in the same position that they would be in the patient's mouth. So you do not want to have this denture flipped upside down. If you do, the dual scan will not work. And so hit next once we know that we have the denture captured within that box. And you see it's calculating, it's matching up all the fiducials at this point, and it marries the prosthesis together, and you can see the scanning prosthesis is in place. And this is just a little feature where you can highlight intaglio surface, and that estimates where the gum tissue is during the planning process. And I'll just do this really quickly here. So a little bit more, we're almost done. We're getting there, we're almost done. But this is just something for when you're planning. You can see where the soft tissue is. Alright, that looks good. Hit finish. And so there is our dual scan prosthesis in place, and the position does look correct. You can verify that even further. So I'm going to actually remove the gum tissue for now, but we can look at our prosthesis and verify it further. And if you look, the fiducials are all matched up. And so we do have a correct position. The other thing to look at is look at the denture in this fashion. And what's interesting, you can see, so now you can tell the difference where the gum tissue is here and where the prosthesis is. So that's the advantage of doing the dual scan. So dual scan prosthesis is one scan of the prosthesis alone and then another scan of the prosthesis with the patient. So hope you enjoyed that demonstration of dual scan. Before we get off of this, I just want to show you one last thing. I want to show you what a dual scan looks like that is not going to work for planning. If you look here, you definitely can tell where the gum tissue is and where the denture is. So the denture is actually tipped down, and that is not a good scenario for planning or ordering a mucosa-borne guide. If you order a mucosa-borne guide, the guide is going to look exactly like the denture and fit into place like the denture. You can imagine if you plan your surgery off of this and you order a guide, the guide then fits intimately with the palate, and you can see how it would change the orientation of the implant. So this is not a good dual scan, and this is not one that you'd want to plan off of. I'll show you, we have a picture of the scan redone. So this is a new dual scan, and you can see we cannot see the transition from the gingiva to the denture. That's a good dual scan. And so now we just need to import the scan of just the prosthesis alone, and then we can start our planning. And this will be a very accurate mucosa-borne guide. All right. Well, hope you enjoyed that demonstration, and on to optical scanning. All right. In smart scanning, the second technique that I wanted to show you was optical scanning. What's nice about this is that there's no scatter. The DICOM files that are acquired from the cone beam CT may have scatter, but optical scanning eliminates that. Also, what's nice about the optical scan technique is it allows the practitioner to plan the final prosthetics after the cone beam CT is made. So in our practice, if we see a patient on exam and we're able to get a cone beam CT that day, we can still use that CT for our final planning. We don't need to get the patient back with a barium scanning prosthesis and rescan them, and so we can just use the original scan with the optical scanning technique. You can either digitize the patient's mouth directly, or you can you make an impression and pour up a model. If there is a model, these are some examples of models that don't work, especially if you're doing a tooth-borne guide. On the one on the lower left here, you can see there's no teeth. That's not going to work very well. Also, the base is not very stable for positioning in the model scanner. If you're using a tooth-borne guide and you order one, but you send a model in with no teeth, that does not work either, and that's occurred. And then also, if you have a model scanner, the model scanners don't always accommodate the mounting, so it's good to remove the model off of the mounting for digitizing in a model scanner. All right, so let's look at an example in the planning software. So here's an example of a patient who we've actually seen previously, and you can see that we're missing tooth number 19, and our goal is to input the final prosthetic data, also input the patient's dental arch without the prosthetic data, because the optical scan will also be used for creating the surgical guide. And so we're going to need an optical scan of the patient's arch with and without the final prosthetics. The final prosthetics helps in the planning. Without the final prosthetics, it helps with the surgical guide. So, all right, let's import the optical scan now. So in Implant, the software that we use in our practice, there's an optical scan wizard, just like you saw the dual scan wizard. And so I'm choosing other scanner. The file that I'm looking for is an STL file. This was supplied by the lab. And we're going to do the lower without a wax up. We can do it with and without a wax up. But I'm just going to do without a wax up for y'all. Alright, so there is the STL file of the patient's lower arch without the final prosthetics in place. So this is important for fabricating the surgical guide. So it's fairly simple how you do it. You just click on common points between both of the windows. So I'm going to zoom in just a little bit more. Tip it down here. So we're just going to touch some common points, and you typically, once you get 3 points, things start to line up. Alright, so let's keep going here. And again, you can zoom in and be even more accurate, but usually once you get 3, it snaps it right into place, and then if you add a few more points, it just gets it that much more accurate. Now, even after you do this and do your planning, Implant will go through and just double check, make sure there's a quality check on how you married up the optical scan with the DICOM. As you can see, we don't have a ton of scatter that we're seeing. We cleaned up a lot of it. But if you have somebody who has a ton of scatter, sometimes the only thing you can see are the cusp tips, and you can line things up. But Implant or whatever software company that you're using will usually just verify that that the optical scan is merged appropriately. So now that it's merged, we'll hit next, and then we can do some final tweaking if we want to, but I'm going to hit finish, and there it is in place. And I've previously inputted the prosthetic data, and I'll show you that here in a second. We just got to wait for it to load. Alright, so it's loaded. The optical scan is in place. It's registered. That's kind of the buzzword for it, registration. And then here, I merged this previously. That's the final prosthetics, and we can do all of our planning off of that. If we place our implant into the site, you can see we can really hone the path of draw. And there's some other things that we can do with this too that we'll show here in just a little bit. So hopefully you enjoyed that demonstration of optical scanning. All right, we've been through planning and scanning. Our next objective is surgery. And so the key point for smart surgery is it allows the surgeon to more predictively deliver the foundation for the final prosthetic plan. Because the final prosthetics have already been considered. The abutment angulation is already considered. The screw versus cement retained restoration is already considered. The type of guidance is predetermined. Just make sure that your guide fits. It's very important before starting the surgery. And then prior to surgery, any anatomic challenges in hard tissue are considered with cone beam CT. We don't want to forget the soft tissue either. There's different types of guidance. The three main types that are used are mucosa-borne guide, tooth-borne guide, bone-borne guide. This guide rests on the mucosa. It's the exact duplication of the denture from the dual scan, so make sure the dual scan denture or prosthesis fits like you want it to at the time of the scan. With the tooth-borne guide, you have to make sure that you have an accurate representation of the patient's dentition, whether it's digitized directly from the patient or if it's from the model. If it's from the model, please make sure that it is as accurate as possible. That sometimes comes up as a question. How accurate do you need the model? How accurate do you need the guide? So typically very accurate. With the bone-borne guide, it rests directly on the bone. You do need a flap. With the mucosa-borne, with the tooth-borne guide, oftentimes you can do flapless technique. There's other types of guidance. There is a guide for reducing bone. There's actually two different ones that I'm showing here. This guide has a slot, and you remove the bone from the slot. With this guide down here, you remove the bone underneath the guide. There are different anatomic challenges. The first challenge we're going to look at is the inferior-alveolar nerve. And typically when I'm planning, I look at the implant to see, okay, am I heading directly at the inferior-alveolar nerve, or am I heading to the side of it? Typically, if you're heading at it, that's a little bit more risky than if you're heading to the side. I wouldn't rather have either one of these, compression or penetration, but penetration is usually the most devastating thing that you can have with any nerve. Do not want to get the nerve in the burr. So approaches for a sinus up fracture. There's different things you can do with a guide when you're planning. If you're planning for an up fracture, you can plan the tip of the implant just to the floor of the sinus. If you're planning for a sinus reconstruction, then you can plan normal length implant, whatever it is that you're planning on doing. With a sinus up fracture, you may plan for a shorter implant, but after the up fracture, you may put a longer implant in. So there may be a difference in the virtual plan versus the final surgical treatment. And then lastly, with the lingual fossa, I encounter this very, very frequently, where you have minimal bone in the posterior mandible. And so one solution that we've come up with, you can graft. However, a solution that we've come up with is placing the implant, and sometimes the tip or a little bit of it will be showing in the lingual fossa. In order to do this, you need to make sure that the tissue is reflected beforehand. Why is there a comfort level for doing this? Well, if you look in this picture, this was an implant that was placed pre-cone beam CT. It's integrated, it's being used in the patient's mouth, and has not caused them any trouble. And here's an extreme example of that as well. I don't try to place this much into the lingual fossa, but this just shows you what's out there, especially prior to the cone beam CT. So hard tissue, to graft or not to graft bone. I see a lot of people, including myself, doing soft tissue surgeries to correct bony defects. With cone beam CT, though, I think you can correct bony defects more and more with bone. Also, with cone beam CT, you can determine if the bone volume is there for short and long-term success. The other thing that can be done and planned very, very precisely is bone reduction. So you can plan for however many millimeters it is that you need to remove in order to place implants to make room for restorative materials. One technique that I've been using and I have confidence using is an osteoperi-osteal tunnel graft. because of the cone beam CT. I know where the bone is, where I want to put it, and how much volume I want to put there. Well, instead of making a crestal incision, we'll make an incision from the side and then use an osteotome or a piezo, whatever it is that you're using. You can use that to create an osteoperosteo flap by heading through the marrow space from either end of the defect. This can be a two-tooth defect. It can be a dentulous arch. There's different approaches that I use for different scenarios, but this is just showing you this one right here. But we're able to basically crack out the bone, and then you pack your particulate from the side, and the more bone you pack, the more bulk you have to your graft, and typically the better the graft gets. It just gets denser and denser because you don't have that crestal incision that has the potential to open up sometimes. So just a technique that I'm using, thanks to Dr. Allen down in Dallas. He's pioneered a lot of the soft tissue tunneling, and Ole Jensen, who's done the osteoperosteo flaps. They were inspirations for doing this, but this has been a helpful technique and one that I'm confident doing because of cone beam. Soft tissue, we definitely don't want to overlook soft tissue for the hard tissue. I like to do flapless surgery. If I can't do flapless, then I'll try to use a mini flap. Try to hardly ever make large flaps that expose large portions of tooth or tissue. Here's an example of flapless versus mini flap. And so if you look here, this is the mucosa-borne guide. There's no teeth to rest it on. There's no bone showing. I place the guide. I basically scratch the surface of the mucosa to see where the implant's going to enter through the tissue. And if it's surrounded by keratinized tissue, I will punch. If it's surrounded by keratinized tissue and non-keratinized, then I'll typically do a mini flap. And so this is what this looks like. So punch all the way across to here, mini flap there. And this is even a better look at things with the parts and pieces. You can see the conicals are in. So these are all punched. That's the mini flap. Typically, the mucosa-borne guide is going to be modified a little bit to account for that mini flap. I do that. I do grind on the guides fairly frequently if I need to make a little mini flap like that. But I typically try to keep the soft tissue intact and the blood supply intact to whatever structure it is it's supplying. So, all right, on to our next objective. All right, so the next objective that we're looking at is smart inventory. With smart inventory, the ability to virtually treatment plan implants and abutments usually decreases the amount of inventory needed for a patient's care. From the surgical standpoint, variable costs don't need to be so variable. These consist of abutments that are pre-selected, implants that are pre-selected, and also bone. Here's an example of a drilling protocol for a guided surgery. And the implant sizes are already picked out. And these are the reference numbers here. So the implants that you determine are feasible for the case are typically the ones that you're going to be placing. For the restorative doc, variable costs don't need to be so variable either. They consist of abutments and the materials for the prosthetics. There's other things that I haven't added to the list, but you can add as needed. But basically, the smart inventory allows you to do something like this. This is a case of Dr. Stephen Lacasios. He poured up some models from guides that we had. This is the mucosa-borne guide. This is a special restorative guide that we had made. But what we're able to do is pre-select all the abutments, cylinders, pre-cut them, and we're able to create the holes in the denture where the implants are, where the cylinders are going to be picked up. So this was all done prior to surgery. All right, looking at a case I did with Dr. Steve Malone. This is going to be a teeth in a day type case, and you can see that we have 6 implants. 4 of the implants we're going to use straight conical abutments on, and 2 of the implants we're going to be using angled abutments on. So we can account for all that and correct so that the implants that are angled, that the angled abutments have the similar to same path of draw as the implants that are placed that will be used with straight conical abutments. And when you look at the final surgical placement of the angle corrected abutments on the implants, you can see here we have good path of draw from the AP standpoint and also from the lateral standpoint. And they matched up very, very well with the implants that had straight conicals placed in the posterior. So with 3D digital dentistry and guided surgery, you definitely can reduce your inventory costs per case. All right, we're on to our next section, which is smart temporaries. A major point that I want to make here is that a multi-unit and single-unit milled temporary can be virtually planned and manufactured based on 3D treatment planning. So the practitioner can fabricate a model and temporary from a mucosa-borne guide or a restorative guide. So that's the first area I want to cover with smart temporaries. You saw this previously. You can see Dr. Locascio made a model in the maxilla, and also in the mandible. The maxillary model was made from the surgical guide that I will be using in surgery, a mucosa-borne surgical guide based off the dual scan. In the lower, we have a restorative guide that was purely manufactured and made to pour up this model. I will not be using that during surgery. The surgical guide that I will use, or actually guides, are a bone reduction guide, and then after the bone reduction guide, a surgical guide for placement of the dental implants. So this was poured up from a separate guide. And you can see Dr. Locascio has used traditional dentures that were used in a dual scan fashion. You can see the dual scan markers in place. He was then able to use the model to cut the holes for the cylinders, upper and lower, and be that much further down the road for the final pickup at the time of the patient's surgery. So the practitioner can have models and temporaries fabricated. And in this case, Dr. Malone and Bob Cutshaw had a denture milled out of PMMA. You can see that it has nice aesthetic teeth, but the denture portion for the gingiva and gum tissue is white, and so there was a nice solution for that. You can see it on here, but the point I want to make is that this temporary was milled denture, which was then picked up in the mouth, and we were able to add the pink acrylic on, or triad material. Once the pickup had occurred, you can see it turns out to have a nice aesthetic result for the patient. So we did that in the upper and the lower, but I thought that was a unique technique for an approach with a temporary and with a milled temporary. also want to show you there's temporaries that can be fabricated, especially for a mucosa-borne type guide, where you're placing the implants flapless, and then your temporary will fit uniquely onto the gum tissue that's there. So the implants are in, abutments are in. This fits uniquely against the tissue and whatever undulation it is in. And we'll see another case like this, but this was the first case that I had done with a milled temporary with Dr. Thomas Myers, and we were just amazed by how the temporary fit in the mounting. You can see that the pin doesn't change when we place the temporaries on the upper and lower after mounting up these digital models. And you'll probably notice these are not the typical models. These are printed models with analogs in place, and just a very unique system, but this is something that is available through Dentsply. Just another case. This is one I did with Dr. Andy Young. Just another multi-unit case. You can see, you've seen this one before. We have the punches here and then the mini flap over here. We talked about that previously. In the lower, we did a bone reduction and then placement of dental implants. Down on the lower here, you can see that. Then we picked up the cylinders in the upper and the lower. And then just want to show you how this unique fit works. So when the temporary was fabricated, it was fabricated to fit uniquely on the patient's tissue. And as you'll see in the next case, there's accommodation already for the cylinders. You don't have to cut any holes or anything. There's the final, and you can see the pickup material just slightly around, and I believe that was SureSim 2 with a micro tip, and I'll show you how that works here in a second. There's another case. It's not a full arch, it's a half arch in the maxilla on the left hand side. Had failing dentition up there, and this is a case of Dr. Tim Williams. You can see where the patient started out. We had a digital model printed out. Here's you can see the pink is the gum tissue. The conicals and cylinders are already picked out. And replacing 4 implants. The patient already has 1 implant here that we'll be using and picking up in the temporary. And so I did plan like we were placing an implant there so that the temporary would have a hole through it to accommodate the cylinder. You'll see that in a second. So here we go with the cylinders in place. And this is a very tight fit. And the cylinder hole in the temporary is made to accommodate the cylinder, plus just a little bit more room for the pickup material. And sometimes the path to draw can just be slightly different with the cylinders, and so there's several different approaches to picking these cylinders up, and we can go into that maybe in another webinar. So maybe Dr. Williams can do that. You can see we have our temp. There's some holes at the cervical margin where each one of the cylinders is going to be, and that is where the micro tip on the material that you're using to pick up the cylinders would go to express in and around the cylinders that you're going to be picking up. And so you can see just testing the fit on the patient after the teeth have been extracted. You can see here's the surgical guide, so we're going to place an implant here, 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 and here. It's already an implant there, but we planned like we were going to place one there because there is an implant at that site. We wanted to have a hole in the temporary to pick up that cylinder. You can see there's our implants in place, and you can see here there's SureSim with a micro tip being expressed around that cylinder. So there's the final occlusion and fit, and that's compared to the original. And the patient did very well, went around like this for about 5 months, and has the final. Alright, we're almost done. We're moving on to smart final abutments, which is a really exciting thing that you all have access to if you want. Just a couple words about smart final abutments. A custom final abutment is able to be pre-planned and manufactured prior to the implant surgery now. The custom final abutments can be placed at the time of surgery. And then taking the abutment on and off numerous times can have a negative impact on the surrounding tissue. That's something you hear more and more about. And what's nice about doing a final abutment at the time of surgery, you place the implant, place the abutment, and that's it. You leave it on after that point. So just want to show you this case. This is with Dr. Tim Williams. This is the first case that he had ever done, and it was the first case that I'd ever done. It was a unique experience, but we were able to get a model, have a wax up, and we digitized all that. And you've seen a little bit of this already before. You can see all of our planning. We've got our direction and our depth. Once our surgical planning is done, we can do our planning for the abutment. This is an Atlantis abutment. And then once you order the guide, you are able to have the Atlantis abutment manufactured. And then you can either have the temporary manufactured, or you can make it yourself the day of. And so Bonadin out of New York was the one who helped with this case with the Atlantis abutment. So just want to show you this example in the software. Alright, and so you see the scan here. You see here's the whole volume. We're able to separate out just what we need from the whole volume. And all we're looking at here is the maxilla. We're able to merge the digitized patient's dentition. I'm going to actually remove the bone now so you can just see that. So there's the dentition that's digitized. We're able to place the wax up into the workup, and then we're able to place the implant just like you saw in those screenshots and account for it in the other cuts as well. You can see our planning. And so you take something that starts out as a single implant, and I mean you know a good reason for approaching even a single implant in a guided fashion is for several different reasons: for getting your depth and direction on, but also for placement of a final abutment. And so that was tooth number 4. We also did tooth number 19 in the same place, in the same patient. And again, Dr. Williams is the one who did this with Bonadent, helping out with the abutment. So you can see the depth and direction of the implant. You can see the abutment design was pre-done prior to the surgery. Dr. Williams had to approve this. Atlantis abutment is manufactured and sent to Dr. Williams by Bonadent. And again, you can either have the temporary made by the lab or the practitioner can make it. And I can just show you this example in the planning software as well. So we'll switch over. And the same sort of thing. So we have a single implant. We select out the bone and the teeth, add the nerve. See the nerve tracking through down there. Digitize the patient's dentition. I should remove the bone. So you can see the patient's existing dentition. You have the wax up. It's digitized and imported into the implant workup. The implant is placed, accounting for anatomy and depth and direction. And then surgical guide is ordered for placement of the implant as well as the abutment at the same time. And you just go through the routine ordering process that Implant has. Alright, so if we get back to the rest of the case, look at that. So we get our surgical guides back for the maxilla and the mandible. You can see here in the maxilla, did a punch because there's good keratinized tissue, placement of the implant through the guide, and then placement of the abutment. The abutment was made to fit right at the tissue level with the margin. Same thing was true in the lower. We did the mini flap on the lower versus a punch. You can see the final temps, and then you can see the final restorations. And good healthy tissue in both scenarios. Alright, we made it. The last objective that we want to look at is smart collaboration and education. So it's not a long section, but I do want to make this point that collaboration and education allow the prosthetic plan and surgical plan to be understood by the patient, restorative doc, and surgeon. So what are the different ways that we can do this? Well, a web meeting service is fantastic. So we use something called GoToMeeting. It works really well. We're able to share our screen. We're able to either use the mic and speakers or the telephone, and it just makes it really convenient. We actually can slip this in to our day. We're able to schedule it, sometimes even set up something ad hoc. But wherever there's an internet connection and the data that you need to work up a patient, if it's on your computer, you can do that over a web meeting with somebody across town or even another part of the world. I know that I've spent several early mornings waking up around 5:30, planning cases with some of the engineers in Belgium with Materialize and Implant. But it works really well, and we use it with our restorative docs that we work with every day. File transfer service is really helpful if you have larger files, DICOM, movies, whatever it is you're trying to transfer that's just a little bit bigger, where email doesn't really work out. There's different file transfer services. We use Hightail in our practice, and it works really well. So I'm not trying to endorse anything specifically, but just telling you what we do. Screenshots are helpful, so we're able to get screenshots of just about any part of the workup in Implant that we do, and we can take those screenshots and we can easily email them. We can send them via Hightail, whatever it is that we need to do. Same thing with movies. We can make a movie, just like we're making a movie right now for this webinar. You can make PDF files. You can get different templates and populate the templates in whatever program it is that you use, and then export it as a PDF and send it out, and that seems to work really well. Just getting together, actually physically meeting with the patient, showing them the workup on the computer screen is just amazing. I like to do it not just with the patient, but with the restorative doc that we're working with as well, and that's just a very, very powerful tool. It's interesting because the patient ends up telling the restorative doc and myself, more than that they ever would if they had never seen the workup. They actually end up saying, hey, there's the sinus, I don't have enough bone, and now, oh, I get why we need to do a graft beforehand, or why we need to do guided surgery. And they just see the value of the workup and all the work that you did do in order to give them the best care possible. And then one thing that's just invaluable in our practice is a monthly study club. It just is a forum for communication with our restorative docs, and it's just been amazing. It's called the Manhattan Study Club. We meet every month, except for the last couple months of the year when things get busy with the holidays. But it's just a place where we can talk, share cases, talk about specific topics related to 3D, implant dentistry, guided surgery, and other topics, and just get everybody on the same page. And it's a wonderful forum for that. We also have something called the Manhattan Study Club Alliance, which is the staff of the Manhattan Study Club docs. And the staff is able to learn and understand, all the different facets of the technology that we're using in our practice, and we get to understand what everybody else is using in their practice, and it just increases those ties. So it's just, you can really use technology to be of one mind and with whoever it is that you're working with. So just remember that. I mean, the sky is the limit when planning 3D implant dentistry and guided surgery. However, just remember, technology and products should never supersede those sound surgical principles. Technology and products should never supersede sound diagnosis and treatment planning. Always need both of those all along the way. So whether you're planning a single implant case in a guided fashion and possibly doing a final abutment, or doing multiple implants, full arch case, guided surgery is just a wonderful tool for just improving patient care and really eliminating a lot of the troubles on the back end of whether it's a simple implant case or a larger implant case. And I remember receiving this picture from Dr. LoCascio, and he said, "This is why we do guided surgery." So I know it seems like a pretty high mountain to climb. I don't know if everybody knows what mountain that is. It's Everest. I know there's been some troubles in Nepal recently with earthquakes. Our thoughts and prayers go out to them. But I had the opportunity to be there in 2012 and enjoyed taking this picture out of the cockpit of the plane as we were flying on a flying tour of Mount Everest. What's interesting is we were flying at 26,000 feet, the mountain's at 29,000 feet, and climbing and getting higher. What's interesting is we were not above that mountain yet. That was still reaching up further into the sky. So, but I just want to reiterate that the sky is the limit. We haven't reached the top yet with this 3D implant dentistry and guided surgery, and look forward to what there is to come. So, hope you enjoyed today. And if you want to get a hold of me, these are a couple of email addresses that you can email me. Would love to chat, to field some emails, to answer questions about the presentation. Thank you again for your attention, and just thank you for letting me share. And hopefully you enjoy the rest of your day, wherever you're at in the world and whatever time zone you're in. Have a great day. Have a blessed day. All right. Thank you. Bye-bye.